All right, we're going to start. Like I said, we're going to go over all the medications that we carry on the ambulance. This is the 10,000-foot view. Well, the plan is for us to cover them all right now, and then in the coming months, let Doc take like 1 or 2 a month and really kind of deep dive into like why the medication works, why we're giving it, and go as deep as he wants to. But right now, we're just going to hit that 10,000-foot view and kind of cover everything. And then, so he dives a little bit into it, and then I'll kind of talk about from the QI side, like what we're seeing, what is working, and some things that we maybe can see some improvement on for our medication administration before.
So Dietrich is not allowing me to go deep. There's some of the meds that I'll hit some deep dive through a little bit from there. But ultimately in time, again, like everything else, my goal for you guys is more on the physiology, the pathophys, the mechanisms and all that stuff. Because you truly need to know the stuff of what you're using to be able to ultimately treat the patient. So if you don't understand the processes, I mean, I tell my EMT and paramedic students all the time is you have to understand the pathophysiology to be able to take care of the issue. So from that standpoint, how we kind of sort of have it broken down is we'll talk about the EMT medications, then we'll go to the advanced EMT meds. How many advanced EMTs? So tab 9 medication review, so go from there and all right.
So one of the first things before we start covering the medication is we just want to kind of remind everybody of the 6 rights. If we can hit these 6 rights prior to giving them medication, then we can stop a lot of our med errors. Pretty much hopefully all of our med errors, we could stop them if we take just 10 or 15 seconds, take a deep breath, and go over our 6 rights. Nothing's going to change in our patient care in that 10 to 15 seconds that we stop, pull the app out, double check with our partner, talk for a second, and then administer the medication. 30 seconds, doesn't change anything in patient care, right? So taking that, most of our EMTs can read fairly well. So having them with the app out going, hey, this is, we're looking at the app, we're all on the same page, things like that. So first thing is that right medication or right patient. Typically that's not a problem for us. This is going to be more of a problem in the hospital setting, but typically right. We have one patient, we know which patient we're treating, we're good there. Right medication, this is a big deal, right? Clay was making fun of me on Monday because my contact was messed up, so like I'm having to like move like old school, like the vial in and out to read it. But if I pull something out of the cabinet, I have to be able to hand that to my EMT partner or my paramedic partner or a fireman or somebody going, hey, this is Zofran, right? This is ketamine. This is Versed. Like we're all, just take 2 seconds and confirm it, right? I've done it going down the road. Like my partner's driving. I'm like, hey, when you get a second, this is Versed, right? This is Ativan. This is fentanyl. Just double checking, right? And I did an RSI last week, and I was like over cautious. Like, hey, this is ketamine, right? This is what we're doing, right? Because I do not want to screw something up, right? As a training officer, you guys would harass the crap out of me if I mess one up. So confirm that random medication. There again, take that 10 seconds, hold the vial up and go, this is labetalol, right? You can read, right? This is labetalol. Right, you're a fireman. We'll draw pictures for you.
Yeah, draw me a picture. I might find it.
There again, right dose. 2 seconds on the app going, hey, I'm going to give 25 milligrams of Benadryl. You good with that? Like it says right here on the app, 25 to 50 milligrams. I can get our 12.5 to 25 right here. We're good, right? If it's a drug calculation thing and I'm having to draw up, do just a quick, just-in-time training for some drug calculations. Like, hey, I have 0.3 cc's here. This is push-dose epi. I've labeled it. This is what I'm doing. But just a real quick, hey, just confirm we have the right dose. I was on a call last week, and one of the providers was doing push-dose epi, where he took the epi 1 to 10,000, pushed all but 1 cc out, drew up 1 cc, and goes, all right, I have 1 to 100,000. Yes, that's it. There's 10 different ways to do push-dose epi, right? So one of the providers freaked out because he was like, oh, God, what are you doing? I was like, hold on. The calculation's right. He's just doing it different than you are. We're all good. So but that quick conversation there, we can make sure that we're all on the same page. Nothing changed with the patient in that 15-second conversation, but just making sure we're all there. Right route. I know Greg's been talking to a lot of you guys about which ones can go IN. About 5 or 6 of our meds can go IN. But then again, if you have a question about it, pull the app up, and it's going to tell you if you can give that intranasally. Fentanyl is a great one that goes IN, but if you don't know, pull the app out and just double check yourself. The right time, How often do we give epi during cardiac arrest? Every 3 to 5 minutes. How often do you really give epi during cardiac arrest? About every 7, 10 minutes, 15 minutes, right? Because we scroll off. So somebody's got to be holding those box of epis going, hey, we're in PA, we're in systole, VFib, whatever. Here's one, and in 4 minutes, I'm going to push another one, right? But we scroll off during that cardiac arrest. So making sure someone's dedicated those meds on a cardiac arrest, going, hey, it's time for your epi, it's time for your amio, and keeping track of that is important. Right documentation. This is something we've seen, we're struggling with just a little bit. If I'm on the report and I push a medication, who should you document on that report for giving the medication? Me, right? Because if we go to court, do you want me to go with you? Probably, right? So if you've got a provider on scene and they give the medication, they're doing procedure, make sure you document that they're the ones who did it, right? So if Docs pulls up, or if Elrod gets the tube, Elrod needs to be documented getting the tube, not you. If Elrod misses a tube, absolutely document him missing the tube, right? So, but the right documentation, let's just double check that. We talked about it a little bit last month too, that and Meredith will repeat this too, if I sign the report, it means I agree with it, right? So that documentation's got to be good. So if you're signing this, we both own that chart, and we both say it's good at the end of the day. So going back for a mat check, there again, your primary medic is going to pull the med going, I would like to give some Versed, I would like to give some ketamine, I would like to do this, right? You're my secondary, I'm like, hey, we all agree that we're going to go with ketamine on this patient, right? Or fentanyl, or Ativan, Versed, whatever. Yeah, we're in agreement. We're going to confirm to have the right med, maybe the right concentration, because logistics maybe gets to different concentrations every once in a while. So we confirm it. We're going to draw it up. I'm going to, hey, we're cool with me giving 2 cc's, right? Yep, done. Somebody needs to document that as well as a timestamp. Maybe you get a police officer, maybe you get a fireman, maybe you write down your glove, maybe hit timestamp on the Zoll monitor, but somehow that gets documented and timestamped. Okay? If we could do the mat check, the 6 rights, we would eliminate the vast majority of the med errors that we see that we're doing. Any questions on that? Okay.
Okay. So for kind of sort of going down the pathway of our medications again, for EMPs, BLS side, 11 medications that we'll go through, we'll hit. Advanced EMPs add additional 5, and then paramedics will add additional 34 on top of that. So yes, like everything else, I've been having fun with Google Gemini and AI and pulling things in and all that stuff. I know. I've been having fun. So, all right. So, EMTs, first medications, and again, just go down, path and all that stuff. So acetaminophen, Tylenol, the kind of sort of the indications for your fever and your pain control. The theme for a lot of the stuff that we'll see, the majority of our medicines, there's several themes that you'll be having, okay? One of them is something called COX, and the other one is all about calcium. That's really the push and all that stuff. So COX is cyclooxygenase, okay? From the aspect of it's one of the enzymes and all that stuff that goes through and it helps with the formation of certain substances. Specifically, they form thromboxane and prostaglandins, which ultimately form something that's called substance P. Substance P is the pain substance. That's what activates the pain receptors and all that stuff and what causes the pain. Okay? So from this standpoint, the Tylenol, it kind of sort of works in 2 different pathways. So one, it reduces COX formation, but from there, it also gets inside the brain into the hypothalamus, which is where our thermostat is, and it will turn the thermostat down. Okay, that's how it reduces the fever reduction side of the house. EMTs, PO-wise, medications, paramedics for the IV, and of course, we'll look at for advanced EMTs if this will be, if we can get this into the formula. I'm all in favor of that. Because there's really nothing from there. I might just make that decision and go from there. I'll just make the decision. Go.
Jeez.
Dosing 325 to 1,000. Of course, the pediatrics.
We've seen a couple of things here for IV Tylenol. Is our medics are mixing that with fentanyl, and it works really well, especially for your ortho injuries. So go ahead and give, you could give a lower dose of your opioids or your fentanyl. Maybe you give 50 mics of fentanyl, 25 mics of fentanyl with your IV Tylenol for that ortho injury, and it works really, really well. We're not having to overgive the fentanyl on this because of the ortho injury. The other thing, like I said, you guys already mentioned the sepsis protocol. Like you're dropping the temperature significantly every time we get the ER with the IV Tylenol. So if we're dropping that temperature, the pain starts to reduce for our patient, and we're doing lower in temperature and pain just with the IV Tylenol.
For ortho injuries, can I do Toradol and Tylenol? Toradol and Tylenol?
You could, because you're doing ibuprofen basically, but you could. We'll talk about that in a minute.
Yeah, you can give all three if you so desire.
Yeah,
So.
we'll talk a little more when we go to fentanyl. So.
All right. Albuterol, the two main pathways for this, or the indications, of course, is the respiratory side. What respiratory for albuterol? Reactive airway disease, which is asthma, COPD. Okay, this does not mean CHF. Correct? Yes. Okay. Our albuterol does nothing for the CHF patient. Okay, so it's for the reactive airway disease, and from the standpoint of it, how albuterol works, it works in two different pathways. The beta or the sympathetic side of the house. So you have your alphas and your betas. Predominantly for this it's the beta 2 lungs beta 2, and what it does from that standpoint is ultimately you have this G protein, cyclic, the adenylate cyclase, cyclic AMP, which pushes all the way down to the bottom piece of it is calcium. It stops calcium from being released inside the cell from the sarcoplasmic reticulum. When we have calcium, when we decrease calcium, okay, the smooth muscles relax. And that's what opens up or bronchodilates. So inside the lungs and all that stuff, predominantly where our beta 2 receptors are. So again, what I said earlier, the theme is calcium for this. The majority of their medications, if they're going to vasodilate, bronchodilate, it's affecting calcium. If we want to increase the strength of a muscle, we give calcium. Dosing of it, so from the other side of the house, so for the potassium, what it'll also do is it activates the sodium-potassium pump. Okay, pulls potassium in, pushes sodium out, lowers my potassium level down. What's our dose for hyper K for this? How much albuterol are we giving? What? 10 to 20 milligrams, okay? In EMTs, if you have this or if you're thinking this, okay, you can give the albuterol too, okay? Yeah, 2.5, but if we have to, just go. I don't care from that perspective. So it is a high concentration, and that's what lowers the potassium side. 2.5 to 5 for the adults, of course, pediatrics pushing down a little from there.
Just a reminder what Doc's saying, we've seen a couple of times in the QA process, is that the providers document in rails, got edema, history of CHF, we're documenting rails in the lung sounds, and we're giving albuterol. Like, that is not doing a dang thing in the lungs, like giving albuterol for that patient. Makes us feel better, I guess, but it doesn't make the patient feel any better. So CPAP is what we need to go for that route. Also, if we do have a CHF patient that we're giving albuterol to, we actually can make the heart strain worse and actually make the CHF worse by giving the albuterol. So if you just have rails, no albuterol. They need CPAP. If you have a silent chest and you're like, I don't hear anything, and you want to give albuterol to see if they're just that constricted, that's fine. You should have a shark fin on your end tidal as well, but you can go that route. But just for CHF, there's no need to give albuterol.
Aspirin, okay? The life-saving aspirin for acute coronary syndrome. Two things that have actually been proven beneficial for ACS STEMI. If they're having a STEMI, the two things that are beneficial is aspirin and what? No. No. PCI. They need a heart cath. Okay? That is the only thing that's been beneficial, proven beneficial. So yes, aspirin is life-saving. Okay, cath lab, they need the cath lab, okay? Like everything else, aspirin, it works on the cyclic oxygenase. So the COX inhibitor, this is specifically the COX-1 versus the COX-2. The COX-1, what it does from there is it irreversibly binds to the platelets. Even just 81 milligrams is all you really need. But we super saturate it, load it 324 from that perspective because we want to make sure that we hit all the platelets. What's the purpose of the platelet? The platelets, they get sticky. When they touch the fibrin clot and all that stuff, and that's how we form a scab clot formation inside, okay? So what aspirin does is it stops the stickiness. The platelets just kind of sort of slide off and they go off and they stay away from the fibrin clot, okay? 324 oral, go from there.
What we see on the QA side on this one is people are doing the 12 inside the house, they see it's a STEMI, they start moving to the truck, and then when they get into the truck, they load in the truck, then they give the 324 of aspirin. So that's 15, 20 minutes by time we've notified this is a STEMI, and now we're giving our aspirin. We're giving aspirin PO, so it takes time to work. So if you do the 12 lead and you're like, yep, this is a STEMI, you should pull the aspirin out of your bag and give the aspirin right there inside the house. Because you're going to take 15, 20 minutes to get out to the truck, things like that. So that's time for heart muscle. So when we see this as a STEMI, 12 lead, go ahead and give your aspirin right there. Unless they're actively having a GI bleed, give them aspirin. We'll fix everything else later. But unless they're actively saying, hey, I break out in hives, I'm severely allergic to aspirin, I probably wouldn't do it. But if they said they had a GI bleed in the past, if they're having a STEMI, go ahead and give them the 324 of aspirin and move from there. But doing it inside the house, making a little bit faster time, is what we probably need to look at doing.
Maybe a dumb question, but what if they're also having stroke with symptoms in the top?
That's a phone call to med control.
Yeah.
We've had a couple of those.
Yeah, I mean, the aspect is, I don't know if it's going to be if they're a bleed, a hemorrhagic. The likelihood of the problem with just giving a single dose of aspirin, I mean, a lot of patients will take it, and then we go from there. If I have to, I can reverse the DDAVP from that. So if they're truly having a stroke with a STEMI, I would hold off, and the same, like I would hold off on giving the heparin too. So.
Is that breaking up an existing clot or just keeping that one from getting larger?
It keeps it from getting larger from there. None of the medications that we give, except for the TPA, actually break the clot up. So we'll talk about more with the heparin too. It just puts the body in the right state for the body to dissolve it. Okay. Dewey dose. We don't carry it, but we have access to it in a number of different fashions and plays and all that stuff. Dudo is actually a combination of two different medications. The old Mark 1 kit from that standpoint, which they don't really have the Mark 1s anymore. So the Dudo is atropine, and it's 2.1 milligrams of atropine. Why they got that, I don't have no clue. And then from there, it has 600 milligrams of pralidaxime. The piece of it is really in two different pathways, okay? So the atropine is our anticholinergic, so it's going to assist with the sludgem or the dumbbells, organophosphate poisonings that we see. That's what dries them up on the anticholinergic side. Specifically, it works at the muscarinic receptors, the M3, M2, M3 receptor for that. So it'll speed the heart rate up, it'll dry them out, and then has all the other pieces from that when we talk about with atropine. The pralidaxime on the other side of it, the whole purpose of that is it acts like a crowbar. So the organophosphate or the nerve agent, whatever, it'll go in and it'll bind to acetylcholinesterase. Acetylcholinesterase is what breaks down acetylcholine, which in terms that stops the whole parasympathetic side of the house. Pralidaxime goes in and it cleaves it off. It tears it off before it can actually solidify on. Right. So you need the two medications together. From there, the dosing of it is depending on how bad they are. Okay? From the perspective of, If they're mild, you give them 1. If they're moderate, you give them 2. And if they're really severe, you're hitting them with 3 Dewey doses at the same time. So that means they're getting 6 milligrams of atropine and then 1,800 milligrams of pralidoxime. Some of these patients, they're going to take all your atropine out of your ambulance. And as you're driving down the road, you're going to stop at another ambulance, get their atropine, and then you're going to get another atropine, and then get to the hospital ultimately, and then we're just going to give them a whole bunch more. Okay. Stockpiles. There's 2 different caches that we have in the upstate to be able to access with. One's at Prisma, and then one's at Oconee.
Yep, so you should have contact information to Prisma if you need this. You can call them. So supervisor can make the phone call to Prisma, and then they're going to bring it. The pharmacy's going to mix it, and then they'll actually put it on a Prisma ambulance, and then meet us or S unit. So I think the S unit has a kit as well. They will meet us. They also bring security with it too for whatever reason, but they'll meet it. But the supervisor can make that phone call. They have all the information in the QRV to get that en route to us. See if we have an overdose for.
How long does that take?
I don't have any. They seem like it was fairly quick. Like when we talked to them on the phone, like you.
I mean, I wouldn't we don't need to wait for.
Yeah, we're gonna meet them. So,
Yeah.
but.
I think it's gonna take longer than would.
Yeah.
We kind of judge that.
Now, like they do have a tox medic in Oconee, so if it's that he has already in his QRV, he has this stuff. But if we have to mix it going to Greenville, I wouldn't wait, but I could try to meet up with them.
The other flip side of it too is if, we have Clemson football and they have 15, 20, 30 patients, I mean, that's where you have an MCI type piece of it. They'll get notification quickly because the Prisma Health will know about it on both sides, and then the pharmacist, it's already there. It's just literally, it's in a box. It's in a big thing. They just roll it out, drop it onto a flatbed truck, and then it's on the road.
How do you determine the severity of poisoning, like moderate versus severe?
Dumbbells or sludge?
Yeah. Following the symptoms. I mean, if they're pink, frothy sputum, they're altered from that versus.
Would you hit them with 3 right away, or is it like a give them 1, see if they improve, give them another?
Yeah. Okay. Yeah. I mean, if they look mildish, you hit them 1. But I mean, if you walk in the room and they are, peak frothy sputum coming out, their heart rate is 20, their blood pressure is nothing, they're in severe organophosphate poisoning. Diphenhydramine, from the aspect of treating it, is a couple different pathways. One for our allergic reaction, anaphylaxis. Treatment for patients with dystonic reactions. So if we give them something and they start having experimental effects, the tardive dyskinesias, the akathisias, and all that stuff. And then the third piece is for the nausea vomiting, just as an adjunct medication. Specifically, it works at histamine, okay? So it blocks histamine receptors. We have histamine receptors all over our body, in our gut, in our brain, and all that stuff. For our consciousness, or for us to think, okay, we actually have histamine receptors, and that's what keeps us awake. Conversely, if you give them Benadryl, you stop that, and what do? Okay, you guys are already in it right now. I'm going to fall asleep, okay? That's the side effect from there. Some allergic reaction causes inside binds to the receptors and to the cell, specifically the mast cells, and it causes the mast cell degranulation. The histamine gets released out, and that's what causes our anaphylaxis. We stop that by Benadryl. Dosing, PO medics for EMTs, 25 to 50 milligrams from that standpoint. For the nausea, we switched it down to 12.5 to 25.
Yeah, just as a reminder, we still see some people giving that 50 milligrams of Benadryl for vomiting, nausea, things like that. The other thing too is we'll talk about again. I'll remind you when we go to Zofran is you've got to give it a little bit of time.
It hasn't been done.
Right, like give it just a little bit of a time to give the Zofran, see if that helps the nausea, vomiting before we jump onto the Benadryl bandwagon. So what we're seeing is maybe we give some fentanyl, we give 50 mics of fentanyl, we've given Zofran, and then 2 minutes later we're giving Benadryl, and now we've completely snowed our patient that had some minor injury. So just let it work. Give it a few minutes, and then go with your Benadryl or second dose of Zofran. But don't just don't stack those medications.
Do we have pills or anything?
We do not.
Epi, life-saving, okay, wonderful drug. So it has multiple different pathways and purposes and all that stuff. One, for the anaphylaxis side, of course we use in cardiac arrest, our acetylcholine, PEAs and all that stuff. Great for the aspect for the hypertension, wonderful drug for the pediatric hypertension, and then the respiratory side. Epi works at both your alphas and your betas, so it's a true sympathomimetic. It's the same thing as adrenaline in our body. We create it. So alpha 1, beta 1, think constriction. Okay, alpha 1, beta 1, constrict. Alpha 2, beta 2, dilate. Alpha 2, beta 2, so 2 dilates, 1 constricts. So inside the heart, we have predominantly beta 1s. So if it's going to constrict, what it means is it's going to increase the contraction ability, and it's also going to increase the heart rate. So we get both chronotropic and inotropic. Inside the lungs, we have beta 2s. So beta 2s, what do? Is it relaxes, it dilates. So that's why we get the bronchodilation. Periphery, okay? The arms and legs, we have predominantly alpha 1s. What does that do? Squeezes down so the blood pressure the blood gets back to the heart. When I bring blood back to the heart, what does that do to my preload? I increase my preload. So I'm squeezing the heart, so I'm increasing my stroke volume. At the same time, I'm increasing my preload. Okay, and then I'm increasing my heart rate. What does that do to my cardiac output? Increase my cardiac output. So cardiac output is heart rate times stroke volume. That formula from EMT school and all that stuff. So I bring everything up. That's how we take care of the hypertension side. The respiratory side, because we're bronchodilating everything. And then, of course, the cardiac arrest, go from there. Okay. Again, the mechanisms, you have alphas, alpha 1, alpha 2, beta 1, beta 2s, constrictions and dilations and all that stuff. Treatment, dosaging-wise, EMTs, it's part of your anaphylaxis kit, so you can draw it up and administer it. So 0.3 milligrams IM. For the paramedics, depending on if you're going to do push dose epi drip, and go from there.
How are you guys mixing up your push dose epi?
I'm taking a cardiac epi,
Okay.
taking 1 cc out of that, into a 10 cc flush that I pushed 1 cc out of.
Okay. Same thing? Same thing? Anybody else do anything different? Y'all are taking? Okay. So, there's, like I said, multiple different ways. You can take that 10 cc syringe, push out 9, draw up another 9 cc's of normal saline in there. You want to draw out 1. However, you don't take a 1 cc syringe and put 0.3 in it. Like, that's your 30 micrograms, multiple different ways. If you want to mix it into a 100 cc bag and draw off the 100 cc bag, either way. Just know there's more than one way to skin a cat on the push dose epi. And then I already talked about it before, cardiac arrest. Remember, every 4 minutes-ish, we're pushing epi, and then we're maxing out at 3. If I give enough epi to cardiac arrest, I can get a pulse back to a rock, right? I can't get them discharged. So that cardiac arrest, once we get to 3, we're done. If you load them up in the ambulance and they re-arrest again, then you can start over on your 3. But typically, we are stopping at 3 epis on our cardiac arrest. If you got that cardiac arrest, it's a 50-year-old female who's got a narrow complex, a PEA at 70, end titles 30, and you're like, man, I just wish I could put one more epi in just to see. Push it, right? Go for it. Just document why you give the other epi. Just like, hey, due to heart rate being this, end title being this, one more epi was done. Just see. If you get a pulse back, great. But like that, if you document that, then we will review on the QA side. We won't even send you a QA for it. If you don't document that, I'm like, hey, just a reminder, we stop at 3, and then you send me one back going, well, I thought this, and this. Okay. If you put that in your narrative, I wouldn't even worry about the QA flag. So most cardiac arrests are going to stop at 3.
Benadryl still in standing orders says for
physiological, I believe 25 to 50.
Everything's being updated right now for the guidelines. We just had the committee the other day. We're pushing everything out. I'm working on that to build all the new guidelines. And so effective June 1 is when all the new guidelines will come out. So it gives you guys time to review it, Dietrich to talk about it and all that stuff. So yes. Glucose, okay? We must have sugar. If we
You
don't
might
have
want to
sugar,
update your standing orders because it's not on my 12.5 to 5.
have you updated the app?
Yeah, you might need to update.
All right. So we must have glucose in order to survive. If we don't have glucose, we don't live. Broke down in the Krebs cycle, went to the electron transport chain. From that standpoint, I've talked about it before. We have to form the ATP from glucose. So C6H12O6 is broken down ultimately into into CO2 in water. Route-wise, PO for the EMTs, the oral side. Advanced EMTs, of course, given the IV, the D10. So the way kind of so the trick of, if you don't remember, if you don't want to look at the app, it's 3 o'clock in the morning. Take whatever your formulary is. While we carry is D10, which is wonderful because I hate D25 and D50 is the devil from that standpoint. So you take D10, you got to get to 50 or 100. So whatever your drug is, so D10, to get to 50, I need to do 5 mLs, okay, per kilogram. If I want to give them an extra, okay, get to 100, so you do 10 mLs per kilogram of the D10, and that's how much you administer. So just a trick. Get to 50 or 100. So if it's D50, you'd give 1 to 2 mLs of D50. D25, you give 2 to 4 mLs. But we don't care those, which is great.
Good.
Yep. And of course, if you do wake them up, make sure that they eat afterwards. Give them peanut butter jelly sandwiches, peanut butter, as long as they're not allergic. Ibuprofen, okay. Oral medication-wise, ENT administration for both your fevers and the pain control. And we had the question yesterday, or the discussion, was that, well, the ibuprofen and the ketorolac just doesn't work as well as acetaminophen for the fever reduction. Okay? For the ibuprofen and the ketorolac, when we talk about it, these two medications, they only work at COX. So only at the cyclooxygenase. So they stop prostaglandin formation, they stop thromboxane formation, which means they stop inflammation, okay? They stop the substance P formation for the pain, but it's the inflammation side of it that causes the fevers, the temperature, right? So it only has one pathway blocking the thromboxanes and leukotrienes of stopping the fever side of the house. So it takes time to inhibit all that. Unlike the Tylenol also works with downregulating the thermostat inside the brain. That's why the Tylenol works a little bit better for fever reduction. Okay, good. Adults 200 to 400 milligrams, of course pediatrics 10 milligrams from that standpoint. So different pathways. Again, the theme, cyclooxygenase, pain inhibition and all that stuff. Naloxone, Narcan, okay? It specifically, it binds at the mu receptor. Mu got its name from the Greek god Morpheus, who is the, anybody? God of sleep, okay? That's how it got its name, okay? So Morpheus, mu from there. So all our opiate pain works at that receptor. Narcan, it has a higher affinity for the mu receptor. It will push anything off, okay? The Suboxone is about the only thing that's different that it actually has a higher affinity for that, but we'll talk about that in a bit. Right? So what it'll do is pushes off the pain receptor or pushes off the morphine, all that stuff, opens up all the whole channels from there, and they put the patient into withdrawal, okay? So that's why we only give, okay, 0.5 milligrams aliquots. Beforehand, when you walk into the room, what did our police officer friends already do for us?
10 milligrams.
Okay, they've already squirted a whole bunch up the nose and go from there. Okay, so for these patients, what is the indication for naloxone? Okay, respiratory depression, okay, with pinpoint pupils and presumed suspected overdose. Now, if they're breathing 14 times a minute, do they have respiratory problems? No. Do they need Narcan? No, they don't, okay? This is for the patient that you counted and they only have 6, okay? You're not documenting 18, okay? You truly counted they have a respiratory depression.
Yeah, and if you're going to give this in a cardiac arrest, let's give it early. Like if we've been working a cardiac arrest and we're 20 minutes into it, there's absolutely zero reason to give Narcan, right? Because you've probably already you've plastered the vocal cords, you're ventilating them well. There is zero need to put Narcan 20 minutes into a cardiac arrest. If you think this is an opioid overdose, you should start your IVIO access, give your epi, and then give your Narcan right behind it at the same time. Epi, Narcan, that fast. If you think it is. But if you're 20 minutes into this code, there's no need to give Narcan. But if you think you walk in going, this is an overdose, IVIO access, give your epi, give your Narcan. Past that, the science doesn't support giving Narcan.
Nitro, okay? The pathway for this is, of course, for our chest pain. Yes, ma'am.
You said that we were going to talk about it later, because I know that, like you're saying, Suboxone has a higher affinity for the receptors.
Yeah.
Would you give more if you suspected that they were
Well, the Suboxone, the good thing about the Suboxone is that it's a partial mu, and we actually give it for the buprenorphine specifically. We give it for opiate. It has a high. So they usually don't have a respiratory problem with the buprenorphine because it's so long acting and from there.
Gotcha. Yeah, so I was thinking that, like, if we were going to give it for that, we had to give, like,
A crap ton.
yeah.
Yes. And sometimes it's actually easier just to put plastic between their vocal cords and put them on a ventilator. And that's like some of the other newer the metamidine, the xylazine, those medications, all that stuff where they have, or if even the diarrhea medication, it has a mu, and if you take a lot of that, it takes a whole bunch of naloxone to reverse it. It's just easier just to tube them and let them ride a day or two in the ICU. Yep.
What about with there's that one blood pressure medication that requires Narcan if they overdose on it?
Clonidine.
Yeah.
Okay. So catapress and all that stuff. It does have a mu. It may or may not, the Narcan may or may not work with it from that standpoint. But there's some theoretical that you can reverse a little bit of that. All right. Nitro. ACS, so acute coronary syndrome. The other aspect too is for our escape, which is the sympathetic crash and acute pulmonary edema in the hypertensive. For this one, okay, the nitro gets in very similar the aspect of the blood pressure wise. Nitroglycerin is converted to nitric oxide. Nitric oxide then goes to the cyclic GMP. Same route, same pathway as before. From there, ultimately, what does it do? Okay. It lowers calcium. When I lower calcium, what does that do to my muscles? The smooth muscles? Dilates out. Okay? So in the periphery where our smooth muscle are and all that stuff, the veins in the legs, they have the capacitance vessels. They really open up, which allows for fluid to stay there, which in turn keeps fluid away from the heart. So it decreases my preload. When I decrease my preload, what does that do to my stroke volume? I decrease my stroke volume. What does that do to my cardiac output? I decrease my cardiac output. This is how we take care of patients in CHF. We're not letting the fluid get back to the heart. Okay? So from the standpoint, the process is using that. How do we give? What do we do? For chest pain, 0.4 milligrams, okay, for the chest pain times 3. For if they're in true escape, okay, you walk into the room and they are frothy, pink sputum, you hear them outside, okay? Before you even get into the house, you hear them, they're wet, okay? You drop in 3 tabs at the same time, and then you put them on BiPAP and go from there. And they're going, oh my God, we're gonna drop their blood pressure too much. No, okay? That's minuscule to what? I give them 1 milligram. I'll give them 1,000 micrograms in the ED if they come through the door. They can tolerate this if they're in true scape.
Are you applying them before we take a blood pressure?
What?
Or we do it after?
Well, I mean, you walk into the room. I mean, if they're audible and they look like crap, and you're like going, I'm gonna tube this patient or not tube this patient, okay? I mean, yes, you throw this is the patient that has a blood pressure of 220.
They're gonna be hypertensive.
Yeah.
But yeah, please get a blood pressure.
Yeah, I mean, they're doing a sympathy. I mean, yes, get a blood pressure because vital signs are vital. Okay, we need to have our vital signs. So get your blood pressure. And this is the patient that's 180, 200. And you give them the 3 tabs and their blood pressure goes from 180 to 179. Okay? Or 178. And they need a lot of nitro.
We've seen this several times, at least a little bit. I know I've been talking to Greg. Greg's had 2 of them recently where it was like this. They're frothy, they're full, 3 nitro, pop CPAP on, and by the time they get to the hospital, they're talking in full sentences. So we've seen several patients recently, like we thought we were going to have to intubate them, and going this route with nitro, CPAP, we've actually stopped them from getting RSI. So if you do have a patient like this, 3 nitro, get your blood pressure first. CPAP, call for an echo unit, get bi-level on the way because they may do good with bi-level. But at the very least, go ahead and start with CPAP and get that going. You'll see a big difference in your patient very quickly to get this done.
Okay. Oxygen, life-saving, gotta have it, 20% at least. Okay, if we don't have it, we don't live.
So the AHA just did an update on our oxygen guidelines. But we all went through National Registry. Everybody gets what for oxygen? High flow non-rebreather, right? Doesn't matter what you're doing. So I've actually kind of backed off on that. So previously we said 94% on O2 saturation for cardiac patients and stroke patients. They need oxygen. So if you put a pulse ox on and they're reading 90%, give them a little bit of oxygen. If their O2 sat's reading 97% and they're a cardiac or stroke patient, they don't need oxygen. You can leave them off of it. On the flip side, these patients don't do well at 100% O2 saturation. So you get that cardiac arrest, you get Ross back on, we've got them on the ventilator, things are going well, and you've got a pulse ox of 100%. We want to back that back down. We want to back the FiO2 back down because it's probably at 100% where we first started on the FiO2. Starts to back that FiO2 down. We had one the other day with Cassandra Johnson. We went back down to like 50% on the FiO2 to get that O2 sat to go to 98%. 90%, we're good to go. The AHA just rolled out new updates last month or 2 and said that we can actually go to O2 saturation at 90%. So if their O2 sat is 90 and above, they don't need oxygen. If it's below 90, then we start giving oxygen for our stroke and STEMI patients. So not everybody needs high flow non-rebreather in the real world.
Did anything change for traumas at all, or that's still we're trying to?
Yeah, nothing's changed for traumas. We're still going to do, because probably don't have a whole lot of hemoglobin in there, so we do want to saturate it.
The killers for the trauma, of course, the hypoxia, hypothermia, hypovolemia from that standpoint. I mean, do they need a full 15 liters non-rebreather? No. I mean, 2 liters, again, maintaining that 94, 96% range from there. But they still don't even need 100%. All right. Advanced EMTs. So we talked about the EMT side, a couple medications for the advance from that perspective. All right. Cefepime that I talked to or alluded to earlier, this is becoming one of the major new medications for you guys. And how cefepime are the indications for is, of course, our sepsis patients. True sepsis means that they have 2 SIRS criteria plus a source or a suspected source. In the new guidelines that's going to be coming out, we're going to be adding in end-tidal CO2. So they have to have an end-tidal less than 30. Okay? We've done a great job over the past couple of years really getting to and suspecting sepsis and treating. Now, the unfortunate is the hospitals are pushing back going, you guys have done too well and we're actually giving antibiotics to people that we should not be giving antibiotics to. Okay? So we're going to just dial back a little bit. How the cefepime works is it actually goes in and binds to the cell membrane of the gram-negative and gram-positive bacteria, and it just allows for a weakened cell wall, which in turn then allows for our body, the macrophages, to come in and just chew holes into the bacteria and then break it apart. Dosing, 2 grams for adults, and then 50 milligrams per gram for our pediatrics.
So we're no longer doing, we do have to now meet that criteria.
Yeah, we want you to be close. Like, you got to be fairly close. Like, we've had a couple patients, like I made a joke, like we're not even in the ballpark. We're in like in the parking lot over here, and we're giving sepsis protocol when it's actually a stroke. Like we're missing it. So we're way over here. At least be close. Like, you got to be close. You can still put Dietrich said so on your sheet. That's fine. But you got to be close. And then the end tidal is going to be the big ticker there. Like, we know that if we get that low end tidal, that we can pull the trigger on sepsis protocol. But at least be close. At least be able to document why you're going to do sepsis protocol. But it's got to be close. And then long bone fractures.
Q-SOFA sucks.
Okay.
Yeah.
So we're not doing that.
Yeah,
So
we're not
it has
gonna-
to be real close.
Yeah, I mean, yeah, we want to stay inside the house versus, I mean, Q-SOFA is actually more for the ICU and all that stuff where they're looking at there, where the SIRS, and it's not a great thing. The end tidal is the piece of it, and this is actually going to help delineate some of our, is this a true like a viral that we see in December and everybody has flu, okay? Are we going to give antibiotics on everybody? No, because their end tidal usually doesn't dip below 90. Unlike our pneumonia, our UTIs and all that stuff, they're end tidal because they're lactic acid, they're building the lactic acid. So this is truly gonna help everybody in the long run.
If you want to give antibiotics to long bone, we're good with that. Stab wounds, dog bites, like that, we don't really have to give antibiotics for. So, yes, ma'am.
I think one of the bigger things for reasons why I like that we can give it, especially like the patients that have like their medication list includes, Tylenol and a beta blocker, and they're already at baseline altered.
Yeah.
Because
If you got that, you got beta blockers, they taking Tylenol, like that's in the ballpark. Like, that's when I'm thinking, like, when I say you gotta be in the ballpark, that's in the ballpark. Like, you can document your way into that one. But if we're over here, like, in not even close, like, we've got a heart rate of 70, they're 19 years old, they're a Clemson student, we want to get, like, we're over here, we're not even put the car in park yet. But you're in the ballpark if you can say, hey, they've had Tylenol in the last 30 minutes, they're on beta blockers, like, you can document your way into that. That's what we're looking for.
And the other piece of it too is, I mean, we're trying to be good steward of our antibiotics. And cefepime, I mean, it's a strong antibiotic, both the pseudomonal side of it. So we don't want to get the bacteria used to it. So that's kind of sort of one of the pathways of why we're doing this.
So I feel like a lot of the patients that I've seen that are having a sepsis issue, some of them also have medical history that says that they have COPD, they have asthma, they have something like that. Do I need to be able to say that the end tidal is not telling me what I need to know because of this other issue that they have that's going to depress their end tidal or otherwise?
So you're saying that they're going to have an elevated end tidal CO2 because of the COPD is what you're saying, okay? But I mean, if you put on there, I mean, that's going to be a one-off from that perspective. That'll be a play-by-play from there. I mean, yes, we're going to miss several from that standpoint, and that's one of those I'm okay with missing.
is IV Tylenol, that's not an medication?
No, it's a paramedic. Well, depends on what I decide.
So, because I was wondering, like, if you have your sepsis patient, if they're giving cefepime and they're allowed to give fluid.
Yeah,
if you're saying
I'm gonna
two, would they take
I'm gonna probably just make a decision and give IV Tylenol to AEMTs. Yes, I'm just gonna make that executive decision. I won't even tell the state. I don't care. Yeah, yeah. I mean, that's what allows for our AMTs to be able to manage that. So.
What do you get a patient that's already on antibiotics? Do you still give that?
So you don't have to. I mean, if they're already on antibiotics, then the question is, are they in a failed? I mean, if they're truly, I mean, if we get called for, hey, they're now more altered and all that stuff, And that is one of the kind of sort of the criteria that will be. I would, because there's, do you have antibiotic resistance and all that stuff? If they meet the criteria and you have the suspected and they're altered, then yes, just go ahead and give. Anything else?
Yeah. So you said adding in the end title for like screening sepsis or whatever. Right now we have the 4 signs that we want 2 of those in a source. Is the end title just going to be another sign, or is it still 2 of the 4 signs plus they need to have low end title and we need to?
Yeah. So you'll have 2 of the 4, and unfortunately the 4th one you can't do because it's a white blood cell count. Okay. So fever, heart rate, respiratory rate. Okay. From there, so those 2 of those 3. Plus a suspected source, plus an end title less than 30 is going to be our criteria ultimately for initiation of sepsis and giving antibiotics. Now, if you think, their end title's 32, 33, go ahead and draw the blood cultures, have it, from that standpoint. And now if they're coming out of MANA, from there they're going, we have those patients, yes, they just got the Tylenol, they just got that, they're coming out of MANA, okay. Again, this is the one, it's like what Dietrich was saying, this is the 19-year-old from Clemson, okay, that is, it looks like a flu, smells like a flu, they're tachycardic, they're tachypnic, from there, and their end title is 40, they don't need antibiotics. So, yes, use clinical decision, okay, use from the aspect of critical care thinking and all that, okay. And sometimes it depends. And if necessary, if you don't know, who do you need to ask? Who can you ask? Okay. Throw it on the supervisor, and then the supervisor, if they don't know, or call med control going, hey, this is what I have. That's why we have doctors on call. Okay. Call med control. Hey, do you want me to do it? Nah, hold off. We'll go from there. All right. Good? Yep. All right. Glucagon.
Leave it in the box.
So glucagon costs $360 approximately a box.
Don't do this.
So 1 milligram is the cost from that standpoint. So Nikki has a lot of angst, and she gets shakes and tremors and all that stuff when we go from there. So the treatment for it is really 2, the hypoglycemia, and then also the beta blocker overdose. If you look, see, okay, IVIO, okay, IM, and you can give it intranasally, okay, from that stand for. So if you can't get an IV, you don't want to drill them yet, you can give it intranasally, and it works well. What it does is it actually gets into the liver, and it causes the liver to release glycogen. From that standpoint, glycogen then goes through gluconeogenesis, and it forms glucose, which then gets shoved into the Krebs cycle, electron transport chain, and it makes our ATP. The other side of the house with that is, so again, the glycogen is released for our increases in our sugar, but the other side or the other aspect is it can actually bypass the beta receptors. So if we have a beta blocker overdose, right, so low blood pressure and all that stuff, we can give them the glucagon. It gets into the system and it will activate the whole cascade to increase our heart rate, our contractility, and all that stuff. Yes, we only give 1 milligram from that standpoint, okay? Ideally, it's 5 milligrams is the dose. We just don't have that on the truck. We'll take care of that in the hospital from there. So for our beta blocker overdoses, and then the glycogen.
Because we're dumping all the reserve on these patients, these are absolutely, you got to make sure they're eating before we leave. Like before you sign that waiver, you got to make sure they're eating, they've got protein on board, because they don't have anything in reserve. So if it drops again, now we're in big trouble. So these are the patients, hang out a little bit, make them a peanut butter and jelly sandwich, and just hang out with them, watch TV, make sure they're getting something to eat before we sign that waiver and leave them.
Yep. And then also, which patient population has a problem with not having glycogen? Where is it stored? In the liver. So any of your liver patients, your cirrhosis patients, okay? They're not going to have the glycogen store, so the glucagon's potentially not going to work, okay? So for those patients, drill them, give them the D10.
Which, if you have a patient who can't swallow and you can't get an IV and you're considering IM or IN, which would you prefer as a better route?
Yes.
Okay.
Yes. You choose. I don't care. I mean, the intranasal works.
There's a study that says one better.
There's no study that I'm aware of that says that one is better than the other. Okay, the intranasal works. The IM works from that standpoint. The IM it may take a little bit longer. The intramuscular, because it gets into the muscle, then ultimately into the bloodstream. So it may take a little bit longer versus atomizing it, because you have the blood vessels right there, and Kesselbach's plexus and all that stuff. So, ipratropium bromide. So Atrovent. Atrovent is similar to our atropine. Okay, so it's an antimuscarinic medication. This medication is in duonebs. Okay, so some agencies in the upstate, the EMTs will give duoneb. Unfortunately, the scope of practice, it's not in the scope of practice and all that stuff for the EMTs. So just the albuterol. So what it does is again, similar to our atropine, is the interaction of the muscarinics with the M3 receptors. This ultimately then from there goes in with the calcium, causes the calcium to slow down, opens up the smooth muscles and all that stuff. LR, okay. This is our clear for our blood, to increase our blood pressure and all that stuff. What it has in it, okay, it has 130 milligrams of sodium. Our body's 135 to 145. It has about 109 of chloride. Our body's about 95 to 105. The lactate, this isn't lactic acid, this is lactate. So inside the body, actually the lactate gets to the liver and it gets converted to bicarb. So it gives a buffering side of the house. And then it has a little bit of potassium and a little bit of calcium. Adults 25 to 50. 250 to 30 mLs per kilogram. In the pediatrics, you can actually go up to 60 milligrams per kilogram.
With your trauma patients, we can still go and hang LR, but the blood doesn't mix very well with LR. So we can go and hang our LR for a trauma patient, and then when Prisma gets there, the helicopter, Medtrans, whoever gets there, and they're going to switch it to blood, they'll just disconnect the LR, flush the line with normal saline, and then they're able to hang their blood and go that way. They just won't hang them at the exact same time, but they can flush it with saline and then administer blood. So no problems there. And we're not, no current medications that we carry are having problems going through LR.
Yep. If we have to go back to ceftriaxone, that one will crystallize with LR, so we won't. That's the only medication, but we're not carrying that right now. Normal saline is the conversely from this one. It has 154 milliequivalents of sodium. Again, our normal sodium is 135 to 145, so it's more sodium. And then it has 154 milliequivalents of chloride. Again, 95 to 105. So it has a whopping dose of chloride. Chloride is the negative ion or the negative element. Sodium is the positive one. So when you dump a whole bunch of negative inside, what does it do to our pH? It lowers our pH. So these patients, if you have to give them high volumes, okay, 4, 6, 8, 10 liters, okay, you can actually cause a hypochloremic metabolic acidosis. Now, if it's only one, okay, that's fine. If you want to give 2 liters of NS, that's fine. It's not going to really. But if we're starting to get more, so our DKA patients, our HHNS, those patients, you know, they really consider for the LR side.
All right, you ready?
Yep.
Go.
All right. Advanced EMTs, I apologize. The aspect of for Atrovent.
No, mine was a
All right. So for Atrovent, it's still listed as a scope for paramedics. So we'll check on that to see where that lies. So go from there. All right. For the paramedics, medications from there. The first one, my favorite medication, love this. I've loved this medication for years. Great drug from there. The whole purpose of the piece of adenosine is to kind of sort of slow or stop the the electricity through the AV node, which in turn pauses the heart from that perspective.
That's terrible.
So treatment for
Ain't no good.
your
Don't get it more.
SVT, PSVT, and then the Y complex tachy with a pulse. Dose 12 milligrams, pediatrics 0.2 from that perspective. Ideally, this should be through an IV AC from that standpoint. The adenosine will get eaten up quickly once it actually hits the bloodstream from there. In pediatric patients, it's even faster. So if you don't have an IV and you have to go an IO, consider humeral head. There's some literature that actually it'll work there. If you go tibia, it's too far away. It won't get any activation. EJs are great. Yes.
Yeah,
Okay.
that's why the Humor Head IO is our preferred site for IO access. I know we've all been super comfortable with tib-fib, and that's kind of our go-to. But the Humor Head IO is our preferred site for IO access. We can dump a lot more fluid, it holds a lot more fluid, and it dumps right into the atrium. So that IO, Humor Head IO, is our preferred site access to that.
Sternal IO.
Yeah.
Okay. Amio. Amiodarone is, from the aspect of when it came out years ago, it kind of sort of pushed lidocaine out of the way. It's probably all just more marketing piece of it. But now we will go down the pathway from both of those. All right. So for amio, it actually has properties in all 4 classes of our antidysrhythmics. Okay, so class 1 antidysrhythmic is our sodium channels. This is what lidocaine does. Our class 2 antidysrhythmics is our beta blockers, our metoprolol. That's where it affects and goes from there. The class 4, the calcium channel blockers, our cardizem, our verapamil, that's the class 4. And then add on with amio itself is actually a potassium channel blockade. Ultimately, all of them the whole thing is to stop the excitability of the heart, which in turn allows us to do our job and slow the heart rate down or increase the heart to get the heart back to working together. Oops. From the aspect of, again, the mechanisms is the increase PR, decrease the QT intervals and all that stuff. The dosing for the adult, 150 milligrams to 300, depending on with or without a pulse. For the pediatrics, it's the 5 milligrams per kilogram. So the way the trick to remember is amiodarone 5 syllabi, so amiodarone, okay? Amiodarone 5 syllabi, 5 milligram per kilogram.
If you're in a cardiac arrest, so there used to, like if you started with lidocaine, you couldn't go to amio or vice versa. Now it doesn't matter. If you want to start with lidocaine because you're more mature medic and you're used to lidocaine, go to lidocaine. It doesn't work, you can switch to amio, that's fine. Or if you're a newer paramedic, you're like, I love amio, go with amio. And then once you get to 450, switch to lidocaine. But if your amio is what converted your patient, then you need to hang your drip, your maintenance drip. That's in the pump, super easy to plug into. But do your drip. Been some questions about like, all right, when do I do my drip? You have to give your bolus first. So if you haven't given a bolus yet, then you can't do a maintenance drip. So you shouldn't be using an IV pump. So, but your 150 over 10 minutes, like that is your bolus, and then you can do your maintenance drip. But make sure you give your bolus first with your amio, and then if it did convert, that's what you would hang with your conversion with. But no difference with lidocaine versus amio if you want to start with a VFib cardiac arrest.
Atropine, okay, we've already talked about this with our Dewey dope from the aspect of where and how. So the treatment for this, of course, is the bradycardia side to increase the heart rate, but more importantly for the organophosphate side. For some patients, they need a pre-medication of atropine. So if you're going to be intubating, traditionally the pediatric patients from that standpoint, we give them a little bit of atropine to increase the heart rate, stop that whole vagus nerve stimulation and dropping their heart rate and killing them. All right. Again, this is a muscarinic, so it's an anticholinergic. It stops the parasympathetic side of the house. It will have the smooth muscle dilation, increasing the heart rate and all that stuff. For the adults, 0.5 milligram to 2 milligrams. For the kids, it's the 0.02 milligram per kilogram.
So your bradycardic patient, you have two choices for medications, right? If they're bradycardic, you have IV access, you have two choices for meds, right? You have epi and atropine. At what point are you choosing epi versus atropine or atropine versus epi? Heart block, so your high degree blocks, right? So your secondary type 2, your 30 heart blocks may not respond well to atropine, so you can go your epi route. Okay, what else?
You want to increase blood pressure.
Okay, well, you want to increase blood pressure, right? So unstable versus stable, but you've got IV access. That was a discussion yesterday. So if they're unstable, right, the HA still says go to pacing. Because if they're unstable, how easy are we going to be able to get IV access? Probably not easily, right? So put their pacing pads on, pace them, get their blood pressure up, get their heart rate up, and then sedate them, because that's going to not be very comfortable with their pacing. But then, like I said, your high degree blocks, probably not going to respond to atropine. You can go your epi. If you want that blood pressure it's kind of soft, then go your epi. But you have a couple different options there for your bradycardic patients. Just understand why you're giving which medication for which reason.
Yep. And just as a reminder too, again, okay, so if you have acetylcholine, the M2, M3 receptor, cyclic AMP, and then ultimately, okay, anytime we have that, these medications, it's the calcium side of the house. It's the calcium, reduces the calcium, which in turn, it decreases the heart rate, increases the smooth muscle side of it, relaxes the bronchodilation for the inside the lungs and all that stuff.
Yeah.
Buprenorphine, Subutex. This is the new kid in the block from the aspect of what is going to be helping with Lane and for MOD. So for the overuse, the medications for opiate overuse disorders and all that stuff. Okay. Yes, we're going to be using it. We're going through the whole process of getting onto the pilot side to be able to carry it. We have to change our DEA. So this isn't anything that's going to happen in the next month or so. Okay. We will train on it. We'll educate. Because part of this thing is going to be some online med control discussions and all that stuff. So you have the patient that's overdosed, you give them Narcan, and they're now going with withdrawals. I don't like this. I want something different. I want to try to get off opiates altogether. This is where we're going. I have patients that are on buprenorphine that are very productive members of society, working again, that used to be, spending hundreds and hundreds and $100 a week on heroin and all that stuff, okay? So it does have a lot of impact. The buprenorphine, how it works is it's a partial mu agonist, okay? Which means that it'll go in and it'll bind to the mu receptor, which is the opiate receptor, and it will displace everything off. It gets in there and it holds on. So if the heroin's there or the fentanyl and all that stuff, it'll go in and it will push it off completely. So if they're not in what's called the cow, so if they're not in a partial withdrawal already, okay, they need to be in a 5 to 12, they need to be in a moderate withdrawal before we actually give the buprenorphine. If they're chilling and all that stuff, they're great going, hey, I want to get off this, okay, you need to tell them to wait, okay, and then get into partial withdrawal, and then I'll give you the buprenorphine. If you don't, okay, and you give it to them, you will throw them into withdrawal. And then they will be pissed off at you and everybody else, okay? What's the problem with it? Okay, once they get into the withdrawal with the bupe, there's not a lot that we have to give them more bupe potentially to calm them down. But it takes a lot longer for them to actually feel better. The morphine's not gonna do anything because, again, the bupe holds on to that receptor more than the morphine, the fentanyl, the Dilaudid, all that stuff.
So is this one of those patients where you walk into their house and I haven't used in a day or 2 days or whatever?
And they're twitching, they're draining, they've got mydriasis and all that stuff.
But this is not an OD drug.
Yeah, well, if you give them the Narcan, okay, and you've pushed them too far, and now they're in withdrawal going, I hate you because you gave me the Narcan, okay, and I need something, because if you're like going, here's your Narcan, they're going, I don't want to go to the hospital because I want a fix to get rid of this feeling that I'm having. And you're like going, I can give you something, okay. So that's actually if we cause the withdrawal from Narcan, you can give them the buprenorphine because it will displace the naloxone side of it. Naloxone is really short acting.
I like how Keppra is just a maintenance thing.
Exactly.
Procedure, you're just
Yep. So this will actually displace the Narcan, and it actually will help the patients that are in withdrawal that we cause from the naloxone. So they either have to get it through a therapeutic. Okay, love my blue canaries and everything, but they give too much of it, and then now they get the pissed off patient, and they don't want to go to the hospital because they need a fix, or they haven't used it in a couple days, and then they want to do something from there. Ultimately, after that, this is where it becomes Lane's piece of the puzzle. So, of course, you want to not give out his personal cell phone, no call him after 5 o'clock, no weekends, no holidays, no nothing like that. The piece of it is really going to be a matter of, ultimately, how do we get them into a clinic, because we don't want to, the repeat dosages and all that stuff.
No, the training officer of the year doesn't want to answer my question. No, what if they get to the point of them withdrawing where they are aggressive? Would it be contraindicating to give this medicine and try to sedate at the same time?
Well, why are they aggressive? Are they just pissed?
Yeah, from pissed off and,
Are they? This is where the therapeutic conversation and talk going, hey, okay, don't be mad at me. I'm trying to help you. I have a medicine that can help you, okay, from that standpoint. Now, if they're just like too far gone and they're fighting and agitated and not thinking, if you have to go that route, then if you're thinking I'm giving ketamine, no, I'm not giving buprenorphine. If you can walk them back from the edge going, hey, I can help you. I have a medicine that can help you. Just got to calm down, take this, and it takes, 15 to 20 minutes, if not a little bit longer, to kick in, because then you're going to repeat with the cows, and if they're still having, you might give them an additional 8 milligrams. So we'll give them 16, give them an 8, and by that time, hopefully they're chilled out a little bit better. And they are, I have patients all the time that going, I'm very appreciative of this.
Is this to her scenario where if I feel like I need to sedate them for mine and or their safety, is like a benzo or something going to interact with this?
Okay, this is mu receptor. Okay, this is GMP and all that stuff, and we'll talk about the benzos a bit with his. That's the BZD receptors, GABAs, and go from there. Versus the ketamine, which we'll talk about again more in a bit. It's the NMDA receptors. Different receptors, different pathways, and all that stuff. So you give it all.
The ultimate goal of giving this is to get them clean. Like, that's our long-term goal, is to get them clean. We want to be able to start this program, us give the medication, Lane meet with them, and then a year go back going, hey, we got 5 people clean. We got 10, 15, 20 people clean. They're off of their medication. They may be on bupe for the rest of their life, but they're not using heroin. They're not using fentanyl. They're clean. So that is the goal, is to do that, right? So that's why we're starting this process, because we want to say, hey, in the past year, working with this program in Lane, everybody combined, we've gotten 5 people clean. And like, if we can get 5 people clean, 1 person clean, I think that's a big deal for Pickens County.
So is like Lane going to start carrying it first before us, or we're just all going to start carrying it?
Yes.
Yes.
Yeah.
Otherwise, we're like, Lane,
Well,
Yeah, no.
For Lane, it'll be a little bit different just because we have to go a little bit more of the pathway of, for him with the truck versus us. In the ambulance, it's easy. It's locked up. We have it from there. We already have your drug license. He's special.
Couple questions. How long does it last? Is it something that, like, if they didn't want to go to the hospital after receiving it,
24. They have to dose it every 24 hours.
is it something that we would be able to give them, and if they want to go later?
Yeah. So you'd give it if they feel great. I don't want to go to the hospital. Here's the waiver. It's the same thing as if you gave them naloxone and they didn't want to go to the hospital. Here's the. As long as they have medical decision-making capacity, they understand risk and benefits, and go from there. Then again, it's. Between primary care, getting into the clinics, the pain stuff, plugging them in with Lane. Ultimately, all this is going to go back to him. Okay, if you guys give us some Suboxone or the buprenorphine and all that stuff, it's going to him, and he's going to be doing follow-ups and from there.
So, and then when that 24 hours, so if the process receptors again,
they won't have to use it again because it's bound to the receptor. So they feel good. Their mu receptor is saturated is good. Okay. It won't because the buprenorphine has a higher affinity for the mu receptor. So they can use the fentanyl, they can use the heroin, but it's not going to give them anything more. Good questions. Anything else?
What if the half-life of the heroin or something, if they decided to use again, like they just wanted to, right? And then the buprenorphine starts to go away and the heroin comes back.
I mean, heroin is an hour, 2 hours max-ish. I mean, it's all fentanyl, and I mean, fentanyl is, or the carfentanil, but even from that standpoint, I mean, the fentanyl that we're having it's shorter than this. Yeah.
We'll have more information coming out.
Yep. Good questions. More education. Trust me, we're going to get education on this. A lot. Calcium. Okay. Calcium, we got to have it. We talked about earlier, just from the aspect of with the contractions, either with nitroglycerin, how it works, from the aspect of the atropine, how that works. We have to have calcium. Okay. From the aspect of the therapeutic side of it, or why do we use it? Predominantly it's for our calcium channel blocker overdoses. Okay, so someone took too much. You have the little kid that got into grandma's stash, or hey, I wanted to kill myself. Like I had a conversation the other day with Looper. Okay, after we had this talk, he calls me going, hey, I had this patient. What do I need to do from that standpoint? For the patients with hyperkalemia and they have wide complex QRS. So they're getting into that, the QRS is widening, or they're going to go into the sinusoidal. Okay, this is the patients. Who has hyperkalemia of wide complex QRS? Renal failure, or dialysis patients. Okay, that's the patient population. Hydrofluoric acid, we don't see a lot of it, so HF in this area. Where I was up in Ohio, I had a plant that had 100% hydrofluoric acid. Okay, so real bad problems from there, and it actually will leach the calcium out of our body.
Gotta go to Woodruff Road.
The last one is with the magnesium sulfate. Okay, which patient population has an overdose of mag sulfate? We cause it. It's our preeclamptic patients. Okay, so they're preeclamptic. We give them the mag, and they just go too far. Okay, and they stop. They get muscle relax and all that stuff from there. Right. What it does inside the liver, the calcium gluconate is 3 times the size of calcium chloride. It has to get into the liver, gets converted over to the elemental form, which then we're able to use. So in a cardiac arrest, okay, it may take a little bit of time for it to do its job. Because again, it has to get into the liver to go from there. Conversely, liver patients, they have a problem with this converting it over. So again, from that perspective. What does it do? Calcium, it binds to the muscles, helps the aspect of the contraction, smooth muscle contractility and all that stuff. And then the hydrofluoric acid. Dosaging 3,000 milligrams for that, and then 60 milligrams per kilogram for the pediatrics.
Those are 1,000 milligrams in here too.
And the dose is 3,000.
Okay.
What?
All right. I'll ask about that.
The calcium gluconate is
They have half
1,000.
a loaf or
And then
half
here
a
too.
loaf, I guess.
Okay.
So we only have 2,000.
Okay. We'll find out about that. I'll make a note.
Well, piggybacking on, okay, let's talk about diltiazem. Diltiazem is a calcium channel blocker overdose. So it is specifically, okay, what class is it? It is a class 4 antidysrhythmic, okay? So class 1 is the sodium channel, class 2 is our beta blocker, class 3 is potassium, class 4, okay, is the calcium channels. What it does is it slows the calcium going through so you don't have the contraction through or the speed of the electricity going through the heart and all that stuff. Dose, okay, 0.25 milligram per kilogram, repeat dose of 0.35 from that standpoint. Dopamine.
Skip.
Okay.
Anderson County.
Yeah, let me review.
We still have, just in case. Okay. Atominate. Literature is coming out, atominate versus ketamine, in the aspect of for induction agent for medication-assisted intubations. Specifically, how atominate works, it's like any of the other sedatives, so midazolam, Valium, lorazepam, it all works at GABA, so gamma-aminobutyric acid. What does GABA do? It turns the light switch off. Okay, the lights are on, it turns the light switch off. Inside the brain from there. So a couple months ago, research came out which gave ketamine a black eye. From the perspective of, we're always taught that ketamine is, it'll increase the blood pressure, it increases the heart rate and all that stuff. Well, they actually showed that the ketamine during induction may not be as cardioprotective as we thought it was. They actually had a drop in blood pressure for a number of patients. Atominate didn't have that same effect, okay? Ketamine's still a great drug, still works. I would still use it. Atominate from there, it may be a little bit more protective. We're also taught too about the adrenal suppression for atominate. Again, the literature that was in rat models, in humans and all that stuff, it may not be as robust as we think it is. Okay, so don't worry about the adrenal suppression side if we're giving the atominate. Still say, tell people, hey, I gave it. If they have blood pressure issues, I would still treat, or consider treating with solid Medrol from that standpoint. For the medication, 0.3 milligram per kilogram, and then for the MSOG group and all that stuff, if they have to get somebody off the mountain, they can do some procedural sedation, 0.1 milligram per kilogram, if they have to relocate. Of course, they're already calling me, going from there.
Just as a reminder for atominate with an RSI, if we do have patients that has a soft blood pressure, let's resuscitate them prior to the atominate. If we've got a soft blood pressure, let's give push-ups, epi drip, or levo, whatever your drug of choice is, but let's resuscitate them before we give the atominate. Right? We don't want to give the atominate going, oh crap, my blood pressure's off, and now we're behind the game on the RSI. So make sure that we resuscitate our RSIs prior to atominate.
Okay. Fentanyl, similar to morphine from the aspect, we've talked about the buprenorphine, naloxone, they all again work at that mu receptor, okay? This is a mu receptor agonist, means that it activates the mu receptor, which in turn gives us our pain reduction and all that stuff. 25 to 100 micrograms, pediatrics is your 1 microgram per kilogram from that perspective. For the medication assisted, it takes a long time. It's not the greatest, okay? But if we don't have anything, we don't have ketamine, we don't have atominate, you can use it for the medication assisted.
With the fentanyl, just remember on the pediatric side, at the top left corner, it says 16 years of age or less. So sometimes that catches people on the pediatric dose for fentanyl. So 16 years of age less. If you have a 220-pound 14-year-old that plays for Pickens High School on the line, just make a phone call. Like, just say, hey, this is a big kid. I need some more pain meds than what I'm allowed to give. Just make a phone call.
And I mean, that's a 200-pound. He's going to give 100 micrograms of fentanyl anyway. So go from there. All right. And also for the kids, if you don't want to stick them, okay, fentanyl in kids intranasally is wonderful. Okay, squirt a little bit up their nose and chill them out. Okay, take care of their pain from there. Still 0.1 milligram per kilogram. Yep. Haloperidol, for us and the behavioral emergency side of the house, as we, from there, we have to be able to use. What it does is our schizophrenics, they have too much dopamine, so we have to stop that. And that's what haloperidol does, is it stops dopamine at the D2 receptor and chills them out. Right? So it calms them down. I use it in the ED and all that stuff. Potentially in time we may bring it about. It's actually a good antiemetic. So for nausea, vomiting, and all that stuff. For the behavioral side, 5 milligrams IM, pediatrics, the 0.05 milligram per kilogram. Heparin, okay. Again, what's the two life-saving procedures or things for STEMIs? Aspirin in, PCI, okay? Heparin is not a life-saving intervention, okay? We do give it, but it is not required. How heparin, what it does, heparin binds to the AT3, so the antithrombin 3, activates the system from that, which stops clot formation, okay? Our body then goes in behind it and actually breaks down the clots. Heparin does not break down clots at all, okay? Our body's doing it. We just put the body in the right state for the clot breaking down side to work better than the clot building up side, okay? 5,000 units IV, go from there.
In studies, is not making the problem worse not considered life-saving?
Well, it takes time for the clot to be broken down by our body.
And
So,
5,000 units is hardly, it's a low dose for heparin.
Yeah. I mean, we'll load some patients with 3,000 to 5,000 and then put them on a heparin drip and then check them from there. The acute treatment for that is
More therapeutic after the fact.
exactly. Yep. I mean, that's the same like with clopidogrel and all those other ones. Hydroxycobalamin. We don't have it. I'm trying to push Chief Gibson to get it. And it's not so much for the patient side, it's more for my firefighter side, okay? So if you guys go down in a fire, and we know the unfortunate, the CO poisoning and the cyanide, those as the two major culprits, okay? If we do happen to pull a patient out, Greenville
City carries it. I think I've used it like 5 times in the last year.
Yeah, so Greenville has, I think Oconee has 2. Of course, they have it at the hospitals from there. So what happens is the hydroxycobalamin is kind of sort of broken apart. It's the cobalamin binds to the cyanide, and it becomes really expensive vitamin B12, okay, which then we pee out. So nothing like giving a medication that's in a red glass bottle, okay, that's dripping down this red line and you're injecting in. So almost like the boys with the compound V from that standpoint. So instead of dripping blue, and they will, if you give it, they turn red, okay? Their body's red, their pee's red, their eyes, everything is red from there, which looks kind of scary, go from there, okay? But it is, you're taking all the cyanide process, so the cyanide toxicity, fire and all that stuff, if they're in a cardiac arrest in a fire.
Is it like a highlighter red?
It's a red. I mean, it all depends on, yeah. Oh yeah, they're red. Yeah, go look, yeah, you can Google, cyanide and you can see it. Special K, love this drug, okay. Behavioral control, pain medication, of course, with the medication assisted, and then the seizures in the adult population. We had some discussions for the pediatrics. My peds attendings in the EM, they're really residents about starting ketamine on the pediatric seizing patients, okay? Rarely do we ever see a true kid that's in status that we can't break other means and all that stuff. So how ketamine works, it's an NMDA. So the aspect of which medication do we work, how do we do it, okay? This is an NMDA receptor, the agonist and all that stuff. So it breaks either too much of it will put them in a dissociative state, or if they're seizing, it breaks the seizure process, okay? Behavioral, 4 milligrams per kilogram, okay? If this is a 100 kilogram person, 200 pounds, the guidelines, all that stuff, you're giving them 400 milligrams. If it's IVIO, 1 to 2 milligrams from that standpoint, if you can get the IV in, okay? Otherwise, just pop them. We do have the intranasal side, and it works well from that standpoint too. But ideally, the IVIO and the IM is the faster routes for that.
Talking with the physicians about pediatric seizures, they say typically we underdose kids on benzos. Like we underdose them, we don't give that second dose. So just as like, if we do have a kid that is seizing and we can't get a break, they need benzos. Like we can treat them that way. Also on the combative patients, we've had several patients recently that we physically fought. that we had to soft restrain, hard restrain. The sheriff's office put handcuffs on them. Like, this is a big deal. And our crews did not sedate them, right? At some point, like, we got to sedate these people. Like, I don't want to fight. Like, I'm too old to fight. It's for their safety, our safety. We need to sedate them. So ketamine is there. If we are handcuffing a patient in the front yard, they should probably be sedated, right? For their safety and our safety in the back of the ambulance. We can use soft restraints, but if they start breaking soft restraints, you should ketamine them, right? Like, if they're breaking the triangle bandages, ketamine them. If we are having to actively fight him in the front yard with handcuffs in the sheriff's office, you should ketamine him. If we're having to use hard restraints, like they've had to handcuff the 13-year-old to the stretcher, we should ketamine that 13-year-old, right? Because he's going to hurt himself or hurt someone else. So let's make sure for his safety, our safety, that we do that. Like we said before, when you go to do this, talk to the body camera. Like the law enforcement officer, make sure their cameras are turned on, and you're talking to them like you're talking to a jury. We're doing this for your safety, your protection, blah, blah. Like, be nice, be friendly, don't antagonize them, don't push them, but be nice to them and push, and but we're going to do it for their safety. And then once we do that, O2 saturation, entitled, you sit beside them, don't start writing your report behind them, things like that.
Yep. And again, just the pathophys, okay, so it's the NMDA receptor, so it stops the glutamate, which in turn that's causes. So the glutamate is the excite, the GABA is the off, okay? Those are the two opposing, competing neurobrain, the neurotransmitters within the brain. So we're stopping the glutamate from the NMDA versus the benzos is the GABA side. Ketorolac, this is just IV ibuprofen, okay? So cyclooxygenase, from that standpoint, it inhibits the prostaglandin and the thromboxane, okay? So it decreases substance P, and it helps with the pain. Also the other side of the fever reduction and all that stuff. It doesn't have that acetaminophen, like acetaminophen, where it doesn't turn down the thermostat inside the hypothalamus, okay? This is just IV ibuprofen, okay? IVIM, your 10 to 15 milligrams, your IV, and then 30 milligrams for the IM side.
Toradol is going to work really good for kidney stones and for migraines. Like, that's the two spots it really does well. We've seen it work really well for kidney stones and migraines for our patients. Like I said, we're still waiting to hear about the advanced we'll be able to do it. But there again, kidney stones, migraines.
Labetalol. High blood pressure medicine from that standpoint, it actually has, it's the selective 1-alpha antagonist, okay? And then it has a little bit of the beta blocker. So it's in that class 2 antidiuretic. It's not the greatest from that standpoint. So we talked about it, okay? Beta 1, heart, beta 2, lungs, alpha 1, extremities, okay? So what it does is it stops the muscles or the blood vessels, all that stuff from constricting inside the periphery. So the arms and legs opens them up. When I open up a blood vessel, what happens to the blood? Pools that area, decreases the preload. When I decrease the preload, what do I do to my stroke volume? Stroke volume goes down, cardiac output goes down, my blood pressure goes down. Okay? That's the pathophys behind that. 20 milligrams, aliquots from that standpoint, up to a max of 300 milligrams. The question yesterday, of course, was, well, what about the stroke patients and blood pressure and all that stuff? We'll be changing in the neurologists. They don't want us to treat blood pressure for stroke patients unless they're greater than 220. Okay, their literature actually shows to allow them to rate. So if they're in that 180 to 220, we do nothing with it. Now, if they're going to give TXA or TNK, they can lower the blood pressure less than 180 in the ED, okay? And they'll give a crap ton of this or put them on an cardiospine drip and all that stuff.
So are we worried about dropping it too fast so they would actually, if they're not having a stroke, giving them a stroke like a watershed type stroke?
Exactly, yep. So they're just going to say, because if they're not a TNK patient, they'll let some of them ride at 200, 215.
I remember you saying with the labetalol that you were emphasizing that they should be symptomatic.
Yes, yep.
Even if they got like a pressure of like 80 and they're chilling on the stretcher, you leave them be.
Just let them be. Yep, they need to be symptomatic, which is ST changes, vision disturbances, having a stroke. What? Not dizziness. Nope. Altered, not headache.
Yeah, headaches.
They need to be altered. They need to have ST changes. They need to have end organ damage. Okay? End organ damage. I can't see out of one of my eye. Okay? That's an end organ damage. Chest pain if they're having ST changes and all that stuff. Okay? And it's a gray zone. I mean, if they're sitting at 220 and they're having crushing chest pain,
You need to do nitro for the chest pain.
Yeah.
After you take their blood pressure.
Yeah. And documenting that you're not giving it for the blood pressure, you're giving it for the chest pain. Yeah. Capra, levetiracetam. What it does is it kind of sort of stops the neuronal cells inside the brain and all that stuff becoming too pissed off, and it calms them down. Okay. You get on scene, patient seizing. It takes you 5 minutes to get on scene. By definition, what is status? More than 5 minutes, or they've had multiple seizures back to back without return of consciousness. Perfect. Okay. We've drilled home hard and all that stuff. So they, by definition, if you get on scene and they're seizing, they are in status. So give them the benzos. How much benzos? A crap ton. Okay. Okay. You give enough benzo until they stop seizing or they stop breathing, then you tube them, and then you give them more. Okay? And at the same time, you're giving them the levetiracetam because it's going to work the backdoor channel. We'll talk more about the benzos in a second. The dose, 2,000 milligrams. The pediatric is going to get changed to 60 milligrams per kilogram up to the 2,000. Technically, the adult dose is 4,500, but we're just not carrying that much Keppra on. Okay?
Most people are just dripping this in. Put it 2,000 into a 100 cc bag and let it run. And that's the easiest way to give this. So instead of standing there with a syringe, trying to draw it outside that, just put it into a 100 cc bag and drip it in.
Lidocaine, similar from the aspect of the amiodarone. This is just specific though. This is the sodium channel. So this is the class 1 channel blockade and all that stuff that we talked about. So the Von Williams classification. Again, sodium is class 1. It stops the influx and all that stuff. And then you have the other 3 from that standpoint. Okay? You can choose. If you want to go lidocaine first in your cardiac arrest, go lidocaine first. Okay? I love lidocaine. Great drug. Okay? If you want to do amio first, use it. If you give the amio and they're still having problems, give them the lidocaine. If they convert with the lidocaine, put them on the lidocaine drip. Okay? Cardiac arrest, 1 milligram per kilogram. For if you drill them, which I still don't understand this, advanced EMTs can drill, but we can't give them lidocaine for the help with the pain. Sorry. Go from there. Okay?
Is there a point where you shouldn't use lidocaine for the IO pain control based on something else that you've seen, or is it to be the next?
I mean, if they're in a cardiac arrest and you drill them, yeah.
Well, I mean, okay, so like I have a patient with blood pressure of 40 over 20, right? And I drill them while they're awake. Is that going to be negligible to
Yeah.
do anything to them?
Yeah, I mean, once you push the saline and all that stuff, I mean, the blood pressure is going to go up because they're going to be screaming. Yeah, it's again, they say it's not the IO that hurts, it's when you flush it. Yeah, so I mean, their blood pressure may go up with the flush. But I mean, it's like anything else. Let's be humane for our patients.
If you do your lidocaine drip, that's in the pump. So you don't have to do your clot method anymore, for those who remember that. Yeah, but that's in the pump as well. So if you convert, just plug it into your pump.
Lorazepam, Ativan. Okay, this is the benzos. Okay, so Ativan binds at the BZD receptors. We actually have 2 type 1, the BZD1 and BZD2. They're located all over the body, inside the brain, and all that stuff. Just like alcohol, okay, what does atominate the benzos? It turns or it activates GABA. What does GABA do? Turns off the lights, okay? So that's how it calms everything down within the brain, slows them down. So the anxiety side of it, muscle spasms, it's like fentanyl, it's not the greatest for the medication-assisted side, but if we don't have anything else, it is there. IVIOIM, Ativan's like Valium, is that it's an oil-based product, so it doesn't work well intranasally. Okay. Of course, the unfortunate too is it has to be refrigerated, which then we don't use a lot of it, and Nikki has to throw out a lot of it, and from there.
Good.
Okay. Magnesium, one of the other elemental medications that we use. We have it for the AFib with RVR that added in. Our torsades or the polymorphic V-TAC, our alcoholic patients, patients that have had Flexeril overdose, that they have the QT, which causes them to go into torsades. More importantly for us is our preeclamptic patients. We give the 4 grams from that standpoint. And remember, for the preeclamptic, it's up to 6 weeks if they're having signs and symptoms. Okay, we don't have to do a lot with the preterm labor, and then the respiratory distress. Again, asthma, COPD, and all that stuff. How MAG works is it binds to the calcium channels. Okay, so it stops the type 4 calcium channels. Right? How do we overcome it? We give them calcium. Okay, it pushes out that. Adult dose 2 to 4 grams. Pediatrics is 25 milligram per kilogram.
That 2 to 4 grams, just drip it in. It's a drip.
Methylpred. Okay, why does methylpred take so long to work? Okay, the medicine has to get into the cell, then it has to get into the nucleus, and then it actually has to downregulate the DNA translation to mRNA. All right? And then that gets out and is supposed to get transcribed. So it downregulates the function of the translation of DNA. That takes time. Okay? 6 to 8 hours. Treatment-wise, the allergic reactions, COPD, asthmas, and then from there, if you're starting one blood pressure medication, epinephrine, to raise the blood pressure up, and you're thinking about that you need to add a second one, give them a dose of the Solumedrol. Okay? And what that is supposed to be is actually more for the adrenal insufficiency or the adrenal suppression that's going on. That's why we're giving the Solumedrol. 125 milligrams for adults, and then the 1 milligram per kilogram for the peds. Metoprolol, similar to labetalol in the aspect of its actions. This one is selective beta-1. Okay? One heart. Okay? It works predominantly at the heart. From that standpoint, what is it ultimately affecting? Cyclic MP goes down and it stops. Bottom left-hand corner, it's slowing down calcium. Okay, so it's going to stop calcium. When I decrease calcium, what does it do to my contraction? Decreases my contractility and decreases my inotrope, and that's also how it works with the chronotropic side of it. Okay, so it decreases the contraction, at the same time decreases the heart rate. IVIO, 5 milligrams dosages and all that stuff. Midazolam, just like lorazepam, okay? For this one, it's the BZD, the GABA. The benefit for this one, it's water soluble, which means that you can give it, as an intranasal side, okay? High dose, Rampart study, make sure that we give for the benzos, for seizures and all that stuff, a lot of it. Okay. Morphine, similar from the aspect of the fentanyl as the mu receptor agonist. So it does have that whole process, mu, the cyclic AMP, calcium, and then the stopping of the substance P, which is the pain medications. Up to 10 milligrams for the adults, and then your 0.1 to 0.2 milligram for the pediatrics. Levophed, okay? Yes, in the past, it used to be called Leave 'em Dead because we didn't like it, and then it's the drug of magic of choice and all that stuff. So norepinephrine and our cardiogenic shock, hypertension, all that stuff. This is the opposite of labetalol. Labetalol was the agonist for the alpha-1, or sorry, the antagonist to alpha-1. This is an alpha-1 agonist. So that works where? Where's our alpha-1s predominantly? Arms and legs. Okay, so vasoconstriction, alpha-1 constricts arms and legs blood vessels. That brings blood back to the heart, increases the preload, increases the stroke volume, and that increases the cardiac output. It does have some beta-1 properties from the aspect of the inotropic side of it. It's not a great beta-1 chronotropic. That's why it's good that for that it's not going to really increase the heart rate up. It helps with the squeeze, but it doesn't really increase the heart rate up. And then our dosages go from there.
Your Levo push dose, how are you guys doing that?
Pulling it off of the bag.
Pull it off the bag, right? Pull your 4 cc's off the bag. You can push 1 to 4 cc's off that bag. That's the easiest way to do it. If you want to hang your drip and give the bolus at the same time to kind of get that jump, but then, or if you're in a single wide trailer in 6 Mile and you need push dose, you can do the push dose.
Ondansetron, Zolfran, this is a serotonin. So if it's a 5-HT3 receptor antagonist, so it's a serotonin antagonism, which actually has a couple different properties from that side of it. So inside the brain, it works at the chemotactic trigger zone, which stops the nausea feeling and all that stuff. Inside the down in the gut area, it actually does a little bit of inhibition of the vagus nerve, which calms everything down. Okay, so those are that's the path and all that stuff. Okay, how much to give? I have some cancer patients. They get 32 milligrams at a pop. Okay, so they can do a huge. We get 4 to 8 from there. Sublingual PO, IVIO, IM, intranasal works good from there. Of course, the pediatric dose is the 0.1 milligram per kilogram.
Just remember, it takes time to work, so don't give them the 4 to 8 milligrams of Zofran and then immediately 2 minutes later give them 25 of Benadryl. Like, the doctors are getting grumpy with us about that. So give us some time to work. If it's not working, then you can go the Benadryl route, but just don't stack those.
Yep. It does have a little bit of some in the IV QT prolongation. So if they're on multiple medications, if they're on methadone, they're on this, they're on psychotic medications, all that combined together can cause QT prolongation. Yeah, don't give them 32 milligrams IV. Okay. Rock. It's a non-depolarizing, so what it does is it gets into the neuromuscular junction and it binds to the acetylcholine receptors. It gets in there and it holds on, okay? It doesn't let acetylcholine come in and activate the process. So it doesn't cause a muscle contraction, it just holds on for dear life, which is 45 to 60 minutes from that standpoint, okay? The state's changed, finally, love it, okay? So we're gonna be able to increase, we're gonna go to the true 1 milligram per kilogram. You can actually do 0.6 to 1.2 milligrams, but just 1 milligram per kilogram is kind of sort of the ideal place for that. Gives the quick onset. So now you're 45 to 60-ish seconds onset-wise, and it'll last for 45 to 60 minutes.
Rock doesn't have anything to do with your blood pressure, right? So if we're doing the RSI, there again, we should be resuscitating this patient prior to giving the rock. Like, it has zero to do with your blood pressure. So resuscitate prior to giving the rock. And then if you're gonna intubate the patient, give this paralytic, right? Don't just give etomidate, don't just give ketamine and think that you're gonna pass the tube through the cords. Research data supports that if we give the paralytic, we're gonna be able to see the vocal cords a whole lot easier. So go ahead and give the paralytic. If you're going down that route of MFIing or RSIing, go ahead and give your sedative and then give your paralytic. Like, your paralytic doesn't have anything to do with your blood pressure. You should already have your epi and levo drip going and then resuscitate this patient with a tube through their vocal cords. But give the paralytic.
Sodium bicarb, treatment for our TCA type overdoses or the overdoses causing QRS widening. So any of the tricyclic antidepressants, Flexeril, and then the hyperkalemia. So if we're at a PEA arrest with hyperkalemia, end-stage renal disease and all that stuff. So at the same time for the hyper-K, what it's doing is it's actually taking potassium, pushing potassium into the cell, and helping from that perspective. With the overdose side of it, between the sodium, so you're actually increasing a little bit of the sodium, the type 1 channel, but it's alkalizing and it's buffering the system. Okay, that's the pieces in the process from there. 50 milliequivalents for the adult, and then 1 milliequivalent per kilogram for the kids.
We're not going to do weight-based for adults? Is that kind of low for bigger people?
You can, 50 to 100. Typical dosage, you give them one and then see how it goes, give them another one.
But we should be routinely giving this in cardiac arrest, so kind of gotten away from that. Like, really, what patients are we giving this for in cardiac arrest? Dialysis patients, right? That really should be the only time we're really giving bicarb during a cardiac arrest is a dialysis patient. Other than that, it should not be routinely given anymore.
Sux, conversely to the rocuronium, Sux gets into the neuromuscular. It binds to the acetylcholine receptors. It actually looks like two acetylcholine stuck together, and it activates. So this is a depolarizing agent. Okay, so it causes all the muscles to fire, and then it holds on and it doesn't get broken down. So it doesn't allow the system to repolarize the fire again. That's how we get the flaccid paralysis from this one. Okay, it just holds on. Fortunately, it does fall off at about 5, 6, 7 minutes. So it's not the long acting like our rocuronium. 1.5 milligram per kilogram IVIO. Terbutaline, we have it. It's there just in case we get COVID again. Beta 2 agonist, just like albuterol. This is an IM injection. Tetracaine, similar to our lidocaine, the sodium channel blockade. MSOG for them to be able to help take care of eye problems and all that stuff.
I had a patient who was working in a position from a sonic. He got halon from a thing in his eyes and started having the eye pain from that. Is that something we use?
That's what, yeah, any of that. We don't have it. It's only in their little kits. Yeah, it's in the MSOG kits. TXA, wonderful drug in the aspect of what we're therapy and all that stuff. So how TXA it binds to lysine binding sites on plasminogen. Okay, so here plasminogen, what it does gets converted over, and then the plasmin is what breaks down the clot. TXA comes in, binds to the plasminogen, and it stops it from forming or becoming plasmin, which in turn doesn't allow for the clot to be broken down. Doesn't build the clot up, it just doesn't allow the clot to be broken up. Conversely, it does, you may have it to be a little bit of having some clot formations because you're not breaking them down anymore. The other side of it, so we know, this is the trauma patients and all that stuff where we're trying to protect them. The other piece of it inside the angioedema, when you stop plasminogen activation, the downstream effect of that is something's called calcarein and then ultimately to bradykinin. Bradykinin is the hormone that causes our angioedema. Okay, that's what the angioedema, anaphylaxis, and all that stuff is where the bradykinin is. So just by giving this, we're blocking those two pieces, and that helps with angioedema and then also with the hemorrhage control. We're going to switch it, okay? Just make it easy for everybody with the aspect of 2 grams for the TXA for our trauma patients, and we're going to change it. If you're thinking that they need blood, give the TXA, okay? If you're going to give blood, just go ahead and give the TXA. If you're not going to give the blood, don't worry about it.
So when you think about blood, we've kind of had a couple of instances lately where the CAD notes are reading and they're like, lots of blood, people are panicking. You're like, oh, this guy's probably gonna need blood. And we're waiting until we've left the scene to call for blood. So if you're reading the CAD notes, go ahead and request blood. Go ahead and request Prisma to be en route. We can always cancel them. But let's go ahead and get them on the way, start to come our way. If you get there and your heart rate is above your blood pressure, they need blood. They have a positive shock index greater than 1, right? So you don't have to do any math. If their heart rate is above their blood pressure, they need blood. So go ahead and call Prisma. So get them coming. We can always cancel them. Where the problem comes in is where we're leaving the scene, like, hey, can you call Prisma to meet us on 123? And we're already moving that way, and you're going to meet them at 700 Grove Road instead of 701 Grove, right? So if you're reading the CAD notes, think about blood. If you get there and you're like, this patient, there's a lot of blood on the ground, and their heart rate is higher than their blood pressure, call for blood. You can always cancel it.
Are we considering doing calcium with that?
Not with the TXA, I mean, because you need the calcium helps with the citrate side for inside the blood product. Yeah.
In terms of your documentation, if like they have like a nosebleed and we just, how would you want us to document? Like last time I did like 10 cc's onto a gauze.
Yep.
Is that fine?
Yep, that's fine. Yeah, and we can document topical now. I think we added it in ESO.
You added topical?
Yep.
I wasn't sure if you were.
I'm pretty sure we added it. I thought.
No.
That's stuff that if they're nose for nosebleeds and the autofill on using it in an ESO chart would let me take it below certain.
I think we updated that, but I can double check on that.
There's no way they got that.
Yeah, you're not getting.
On the gauze pad.
Yeah.
Vecuronium is similar to rocuronium. The only difference is it takes a little bit, has a longer onset. So where rock is 45 to a minute and a half, this can take 3 to 5 minutes. Okay, that's why it's not a good induction agent. It's great from the aspect of once they've got paralyzed. If you gave them sucks, if you want to keep them paralyzed, it's great from there. Otherwise, nothing else. Verapamil, similar to our diltiazem on the calcium channel. Just in case we are out of diltiazem, we just have this inside our formulary. Same calcium channel blocker, solar type 4s and all that stuff.
You want to talk real quick?
YouTube channel, we're going to post, we'll get this posted online. So at Prehospital Physician, for the YouTube channel, that's my channel, Dr. Fabiano's from that standpoint. We have, and to go from there.